I would say that when we started planning this project on COVID and global governance, from the start, I knew that Gian Luca would be the best person to give an introduction to the World Health Organization and to do some work for us to separate the myths and rumors about the organization from its reality. So I'm really thrilled that we have you here with us today, Gian Luca. Thanks so much for taking the time.
Yeah, thank you for inviting me, and so apologies again for the oversight.
Yeah, that's fine. Of course, this year, so the World Health Organization's been in the news like never before, I think. And it also seems often like when it gets talked about, at least in the American press, there's a presumption that people already know what the organization is and does and how it operates. And I get the sense that that's not really true, and that for most people, a kind of primer introduction to the institution would be really helpful so they can understand some of the parameters of what the body does. So I was wondering if you might give us a little bit of insight into the kind of basic shape and functioning of the organization as you saw it, so we can then understand more about what it's doing in the current crisis.
Yes, with pleasure. I think sometimes it's a popular misconceptions with many international organizations is between myths and denigration. And also students of international law, of international organizations often are largely limited to the UN, the European Union, maybe the World Bank, and they overlook the technical agencies as maybe less interesting from a legal and governance point of view. But actually, having spent 18 years in WHO, I must say it's a very, very interesting organization and ahead of the curve in many respects, at least within the UN system. So WHO was established in 1946, but they came to life in 1948 when the Constitution entered into force. And that was part of the grand design of the creation of the United Nations system. And sometimes students ask me, so but why an international organization in the field of health? Health still sounds like something relatively internal, domestic, where a global dimension that would justify the existence of an international organization is maybe less understandable than, say, intellectual property or civil aviation, on international maritime transport and so on. But WHO was actually born from a tradition, a legacy of international cooperation and international institution building in the field of health that starts in the mid-19th century. That's something I discovered in joining WHO and started studying a bit of history. And that was largely because of epidemics. So some things never change. Some of the problems that we are experiencing today were already felt in the mid-19th century with the acceleration of trade in particular, and also the movement within the colonial world, largely dominated by the United Kingdom. And so bugs know no border, and epidemics can disrupt travel, trade, and in a way, the accumulation of economic power. So again, not much has changed. And so there was a movement to, first of all, create rules of the game in the form of international conventions, largely devoted to quarantines, but fundamentally to try to harmonize national measures and avoiding trade distorting measures trade taken for the pretext of protecting health. And second, building institutions, because if you want a typical conference diplomacy, soon prove inadequate. And so we have both regional and the first global institutions, one of which, largely unsung, but I think its immediate precursor of WHO, was the health programs of the League of Nations that went beyond just epidemics and started talking about nutrition, child health, vaccination, and so on. So WHO comes out of this legacy, and in particular a legacy of tension between universalism, so they need to have clear rules applicable to all, and regionalism, which is very strong in public health. The fact that you can only address problems if you're close to the ground, and African problems are not European problems. So WHO was born out of this, and it was a bold experiment because, again, I assume that your students have studied international organization, and your excellent book, I think, sort of highlights some of these tensions. In particular, I remember your trinity of international organization as actors, forums, and resources. And that's exactly the tension between being a creatures of states and being an institution that starts living its own life and doing things that go beyond just the pure sum total of what states do. And WHO was a world experiment because it is a strong normative organization, also with strong oversight powers. Really, there was a feeling that in public health, there needs to be a strong hand, both to facilitate the growth of market and second, to protect the world from the spread of disease. So WHO, first of all, has, if we fast pedal to today, has 194 member states. So within the UN system is the most universal. It has one state more than the United Nations. It has, if you look at the Constitution, a huge mandate that goes from the historical core of preventing and controlling epidemics to non-communicable diseases, to facilitating research, to providing emergency assistance, to disseminating information, to promoting the development of international law in the form of treaties, but also in the form strikingly of what we call regulations. So the international health regulation that have come again to the fore with COVID are one of the examples of this particular form of international instruments that again is very bold because it's closer to a Security Council resolution than to a treaty. The plenary body of WHO, the Health Assembly, can adopt regulations by simple majority. So a relatively low number of states can take decisions that can bind the whole membership. And the regulations come into force for all states after certain deadlines, except if you literally opt out in certain ways. So silence is equal to consent. And if you look around beyond the Security Council or very different examples like, say, European Union regulations, there are not many examples of this more sort of parliamentary top-down way to make international law. But there was a strong feeling that in things like the protection from epidemics, you couldn't, the typical treaty route was not adequate. To maybe having 10, 15 years before a treaty comes into force, and sometimes for a minority of states was just not good enough. And so states were prepared to compress the sovereignty through these different forms of international lawmaking. So I don't want to spend too much time, but so just 2 words on the governance. WHO has a, again, plenary body, the Health Assembly, an executive board of 34 members, but strikingly is a very regionalized organization. It's unique within the UN system because it has 6 regions, but the regions are headed by regional directors elected by the respective states. Also, the UN has regional commissions, but the heads of the commissions are appointed by Gutierrez, are appointed by the Director General. In WHO, they're elected leaders. And so that also generated this very centrifugal dynamic. And the history of WHO has been the history of this tug of war between the central power of Geneva and the sort of centrifugal tendencies of these regions that became very autonomous, very independent. And that has also been the history of public health in certain respects. And so that's an important point. In terms of mandate, again, is very broad. If I will talk about COVID in a moment, but to take you maybe beyond COVID and beyond infectious diseases, WHO faces many, public health, global health faced many challenges that sooner or later are dropped in the lap of WHO. A big one is non-communicable diseases, cancer, diabetes, cardiovascular diseases, respiratory diseases. These are the real big killers of the 21st century. Out of 1 million people, about 600,000 every year die of these 4 diseases. And these are the very hard to approach because they have to do with a way of life, with environmental factors, but largely with consumption, tobacco, alcohol, fatty food, carbonated drinks. And here you have huge economic interest behind. And so that's one of the big challenges of WHO, how to help states regulate better in a legal environment which must much more favorable to corporations sometimes than to strong regulatory powers for states. Other big topics are health systems. That's a so-called horizontal approach. If states don't have resilient, sustainable and sustained, well-financed and inclusive, equitable health systems, you have what you had during COVID, the implosion of the health system of even developed states when they're under such severe shocks. And so that's been a refrain of WHO, but as you can see, there's still a lot of work to do, even among the so-called developed states. So a portfolio that goes in many directions, that covers many dimensions, that has nothing to do with healthcare. WHO is not a healthcare organization, it's a public health organization. It has to do with the health status of the society and not of individuals. It's become an intensely political organization. And the politicization, which was always latent, if you want, exploded, I think, during the 1990s. And the driver was very much the HIV/AIDS pandemic, because it brought into WHO human rights that until that point had been like a distant neighbor, security, because infectious diseases are seen more and more as a security threat beyond public health problems. And so this very difficult interplay between a security narrative and a public health narrative, which are quite different. And third, the clash against the wave of neoliberal economy and sort of a political assumption that came in the 90s after the end of the Cold War. Think of WTO, think of the wave of bilateral investment treaties, and how people realize how they are clashing sometimes against public health protection. Think of the incredible prices of medicine when they're protected by patents sometimes. And so the access to antiretrovirals was the battle cry of many NGOs. But also the economic model of the pharmaceutical industry. Think now of all the debate about the COVID vaccine and how difficult it is in really having a multilateral approach, because there are huge interests of the pharmaceutical interests behind. So far from being like a technocratic organization or a talk shop of health regulator, WHO has become intensely political. And sometimes battles are brought from other organizations into WHO. The question of patents and access to medicine is an example. States like Brazil, India, but also Thailand, Malaysia, China, that felt they lost the war in WTO, moved the battle to WHO. And so that has it has polarized the membership, even though it's an epistemic community of health professionals in the end. So when they talk technical stuff, they really agree on a lot of things. But when different politics intrude, then the conversation becomes very difficult. So maybe I will stop here because I can go on for a long time, but just to give a sense of the complexity of what is perceived as a technical agency, but has become, once again, intensely political and caught in the middle of very difficult agendas and also difficult geopolitical rivalries, like now between the US and China.
So you describe really well the broad mandate and the kind of incredibly wide range of topics, of health questions, of tools in the organization. So how is it then that the organization comes to identify certain things as priorities, given that the mandate, it seems, kind of covers pretty much everything on the planet? How does it get narrowed down?
Well, obviously the priorities are defined first and foremost by member states, and they change in the course of time. Certain things don't change, actually. If you look at the agenda of the first Health Assembly, you had malaria and tuberculosis, and they continue to be in the agenda of this Health Assembly. So unfortunately, certain diseases just don't go away. But other priorities change, and they reflect both changing public health challenges, but also the political perceptions. For example, the big revolution in the 70s about moving from a biomedical Western model to a much more bottom-up approach that reflected the priorities of new decolonized countries and so on. So we can say there are certain long-standing priorities, and the infectious diseases and the protection from epidemics is one of them. And then there are changing priorities, or priorities that get sort of more fine-tuned in the course of time, like what I said about health systems. At the same time, like many organizations, WHO is no exception, there is also a tendency to member states, a bit of a failure to focus. So if you look at the agendas of WHO, sometimes you have issues, say, like blindness or certain particular conditions that seem like priorities, but they're actually 5 people and a few $100,000 of budget. So they are there on the website, but there's very little behind. But the inertia, the bureaucratic inertia is strong enough that they are never dropped. So you have this strange schizophrenia among what seems to be an impossibly thin spread organization, but with some core priorities that are defined by states.
I see. The priorities come from states then, for the most part, you think? That they're the drivers?
Yeah, they come from states, but then in certain things, obviously, the Secretariat has a lot of power, shaping the agenda, framing the agenda, and so on. So, for example, the emphasis on health systems, and that's a broader issue, really came from the Secretariat, and then so it became obviously was a mainstream and so on. But as you know, when Director General, Secretary General are leaders and know how to be leaders, they have quite a lot of influence in shaping agendas and putting things at the forefront of the discussion that otherwise would be neglected or would be just the hostage of politics.
I think in the analysis of international organizations, it's often handy to think along 3 lines. One would be what the organization can do, as you've said, from the charter and other legal rules, what they can't do, and then what they actually do. You set out kind of what the WHO can do. What it can't do, presumably, is force governments to take action that they don't feel like taking. So I wonder, what do you think of the limits of the institution?
Well, as you said, there are limits can be seen in different ways. Like most international organizations, regulatory power is limited or almost absent. So WHO, in a way, has what Jan Klabbers called the epistemic authority, as the authority of the credibility of what it does in inducing countries, but not only countries, also many stakeholders, regional governments, public health operators, hospitals, in following, for example, from a normative point of view, its guidelines, its strategies, and so on. So it is not an agency there to bind states. At the same time, as you know very well, the absolute limits of a mandate are very blurred. It really depends on the political consensus and so on. As maybe your students will remember, the WHO got a slap on the wrist from the International Court of Justice back in 1996 when it asked an advisory opinion on the legality of nuclear weapons. And the court said, no, you're gone too far. The legality of nuclear weapons has nothing to do with your mandate. Your mandate is to assist the victims of nuclear war. The legality or illegality of nuclear weapons don't make a difference for your mandate. So there, I think we touched maybe some of the limits. And the limit that the court framed as a limit of the system, of the UN system that was made of technical agencies that had to stay within the boxes. But in a way, WHO was not terribly intimidated by the slap on the wrist, because a few years later, it started negotiating a convention on tobacco control. And that convention is groundbreaking instrument because, as far as I know, is the only multilateral treaties that regulates the marketing and to a certain extent even consumption of a lawful product of mass consumption. It is not cocaine, it's not LSD. It's something you find in a tobacco shop or at the grocery shop. So even that was a line that many people thought could not be crossed. Because if you look at the convention, it talks about taxation, it talks about advertisement, it talks about counterfeiting, it talks about promotion and so on. Things that are not public health, are really economics and trade and intellectual property. And still WHO ventured there, and it's been quite a successful treaty. It has 181 parties, and I think it has turned the page on how we look at the risk factors of the non-communicable diseases that I was mentioning before. So the things that WHO cannot do, again, to me, it's a relative concept. Certainly cannot go into healthcare, because that's not what WHO is. But besides that, and besides maybe some flagrant cases like the legality of nuclear weapons, I think WHO has crossed many lines in extending the boundaries of what it can do or what it couldn't do before, and now it does.
Yeah, so that's interesting because it expands things. But then if we can turn to COVID, that is, as you said, at the heart of the mission of the organization, dealing with epidemics like this. In fact, it sounds like your view is that the WHO has been preparing for an epidemic like this since before the organization was even founded, for 150 years now. So this current situation, the current virus, seems to be exactly what the organization was designed to address. What's your sense of how it responded in the early days and weeks? Was the organization ready, do you think, for something like this, and had a plan to put into action?
Yeah.
How did it go?
Yeah, that's a big question. First of all, WHO had been repeating and repeating and repeating that we could expect the kind of pandemics that we are witnessing now, and that preparedness was crucial if we want to avoid exactly what we are experiencing now. So in that sense, was a bit the prophet that cries in the desert, and not many people listen to it. But it's not the WHO downplayed or was complacent about it. Secondly, this has been a particularly bad outbreak. This disease is vicious, it moves at an incredible speed and ferocity. So it's the perfect storm. And probably it's difficult for any human institution to try to successfully contain something like this. Also something of long duration, and what we have, the tools in the WHO possession are more for acute but shorter outbreaks, not something that goes on for 2 years. And third, if we talk about WHO, we cannot only talk of the Secretariat, we have to talk of states also. Because if there is a successful framework to prevent, prepare, and control, this is not something that can only be managed from a few thousand people sitting in Geneva or in some regional offices. It's something where the Secretariat and states have to work jointly. And so here there were a number of weaknesses, obviously. On the part of WHO, one of the weaknesses was not weakness, but the fact that the law in the books is this international health regulation. And this international health regulation poses constraints to what WHO can do. The accusation against WHO having been too complacent with China, too dependent on the information given by China, is correct. But frankly, WHO legally didn't have much of an alternative. It is not a kind of investigative agency that can second guess and start spying and so on. The regulations already give WHO the authority to consider reports from other sources, but you need to have access to other sources. And in a state where the internet is as tightly controlled as in China, the other sources are not very abundant. So we have some, I think, legal constraints. WHO has reformed itself after the Ebola outbreak. You remember how heavily we were criticized. And WHO established, for the first time in its history, an operational emergency program. WHO has never been an operational agency. It's not WFP, it's not UNHCR. Now it's become also an operational agency that has to be prepared to send people to the field, to mobilize partners, to ship plane loads of, in this case, of masks, testing kits, and so on. And it has done it. So it had to reinvent itself, and that's not a painless or fast process. And so probably it has paid also the fact that still has to finalize its transition. Third, states did not play the role sometimes. We've seen how unprepared health systems were, how much chaos there was, how much the knee-jerk reaction was close the door and go unilaterally instead of trying to cooperate and to show restraint and solidarity. And then sometimes the variables, like again, this rivalry between the US and China, that I think weakened WHO and put it at the center of the zero-sum game, where you're friendly with China, so that means you're an enemy for me. So there were many reasons that can explain why the whole system that is loosely coordinated by WHO was not more successful. If we look things in perspective, and now maybe we don't have a good perspective yet, but having worked inside organization, having seen a bit the constraints of what it means to work there, I think WHO has done a pretty good job in several respects. First of all, in its normative work. WHO has put on the web really incredible amount of guidance with making mistakes, trying to chase in science that was evolving day by day, but has really tried to help and to guide. And not only to guide states, to guide us also. There is a lot of guidance for individuals, even on hand hygiene, on how to put a mask and so on. And this is something that also legally, if you want, goes beyond the typical functionalist blueprint that WHO is a creature of states and it only talks to states. The internet, and in particular, the need to respond to a crisis that touches deep into states, leads WHO to talk to us, to talk to me, to talk to the Canton of Geneva, to talk to the doctor, to talk to the hospital director. And that to me is a big thing. And WHO has done its best. Second, it has helped a lot developing countries. As I said, it has sent a lot of stuff, a lot of protective equipment, testing kits, masks to developing countries, in particular to sub-Saharan Africa. And that's something that wouldn't have been possible even 10 years ago. So things have changed. Third, I think it has exercised leadership. I think Dr. Tedros and WHO made mistakes in January of being too cozy with China. And we can discuss why. And that has damaged its credibility. But if you don't obsess on what happened in January and see things in perspective, to me, you see leadership also. Dr. Tedros has appeared on press briefing 3 times a week, 2 times a week, keeping the message, not picking a fight, saying, don't politicize the pandemics. We need solidarity. We need unity. We are here to save life. That can be seen as rhetoric, but rhetoric that made the front pages of the newspapers and had an influence, I think, in political life. And that to me is leadership. So at the beginning, sorry, I'm making like a ultimate apology of WHO. But so I was trying to bring some perspective of what it did and what it could do. Now we have 2 evaluations going on that will look also, hopefully, and what happened in the first crucial months, and will clear the air, will bring some more clarity. Because there we have a lot of you said, I said, you did, no, you didn't, and so on. And that to me is almost forensic analysis more than, at this point, a sort of sober assessment. We are too close to what happened a few months ago.
You described this new operational role. Do you think that that is going to become a bigger part of the organization as a whole, or is that really COVID specific and emergency specific?
No, I think it will remain. Again, it came as a consequence of Ebola, because there were some of the even most supporting countries that were saying, WHO, you get your act together, because if you fail on Ebola, then why do we have a WHO? And so WHO really had to invent an operational role that it didn't have, and that goes way beyond COVID. WHO received every year, that's what I hear from my colleagues, hundreds, if not thousands, of signals that there are outbreaks here and there. And these have to be filtered down to see which ones reach a certain level of gravity. So COVID is a particular, unfortunately, we've been very unlucky, but has not been the first, neither will it be the last. The point is how serious states are in having a credible, big operational arm of WHO, because it has to be well-financed, well-staffed, and given resources, space to operate, and political support. And this has been, frankly, not good enough. It is a part of its staffing is still not filled. It has like a pot of money to start operating immediately. There was supposed to be $100 million. It never been more than $30–35 million. So it's a typical hypocrisy of states. They put a lot of demands and a lot of expectations, but then, in particular, when if you want urgency and crisis is over and political attention goes in other direction, then the support decreases. I hope that COVID will turn the page. And if we're serious about the role of WHO, that it will be a much stronger operational arm in financial terms, in manpower terms, but also in coordination. WHO it's a very limited agency. It doesn't have thousands and thousands of people. So it relies a lot on partners and networks. But these have also to support what WHO does.
I'd like to hear a little more about the networks, but let me also suggest that anybody who has comments or questions should feel free to chime in.
I see some, there's a question there.
Oh, great. You can also type in the chat if you like, but I'll turn over, if I can, to Karen Alter, who has her hand up. All right.
Thank you. Thanks for this presentation. I can well imagine that there'll be other crises like Ebola and stuff where the WHO will resume its role that it has always played so effectively. But I can also imagine that what you're describing is really a structural situation where the US is not paying for things and China is willing to pay for things. And so I could see this happening again, because when China pays for things, it's not without strings or an intention of message control. And so I guess I'm just wondering structurally, where do you go with this? Like how does the WHO learn a lesson from this period and try to not repeat this story?
Difficult question. First of all, the strings are attached by everybody, not just by China. The US, when the US funding is full of strings. And that's part of the problem, if I can not digress, but expand a little bit my answer, because that talks about the very dysfunctional funding model of WHO, which is again unique within the UN system, because WHO at this point is financed less than 20% by assessed contributions, so the binding contribution, the membership fees, if you want, that are more flexible, and more than 80% by voluntary contributions. So it's incredibly donor-driven, which goes back also to Ian's question about priorities. Sometimes, as Director General Chan said, where there is money, that comes a priority. And it's full of strings, and that's not the good way to operate. China is an interesting question, because President Trump was not too wrong in saying the US gives $500 million a year, China gives 40 million. That's exactly how it is. The financial contribution of China for the moment are very limited. Also because China is still in this sort of developing country mode. It's the second economy in the world, but until not too many years ago, was a recipient of funding from the Global Fund on HIV, AIDS, malaria, and tuberculosis, which are absolutely perverse. So it is still in this developing country mode. It will, for sure, sort of get out of it and discover also the power that comes from financing. So, but I wouldn't exaggerate the polarization between the US and China. I think WHO is the political influence is more diverse and more fragmented than just bipolarism. For example, the BRICS, and leaving aside China, have a tremendous influence. One of the leaders in WHO has always been, for a long time at least, Brazil. Now it's imploding under President Bolsonaro, is really retreating, but has really been one of the leaders in shaping many policies. India also, middle income countries like Indonesia, like Thailand, and so on. So the centers of power are more diverse and more widespread than just this bipolar tension between the US and China. Then, I mean, international organizations have always been victims of big power politics. WHO is nothing new. Think of the UN, think of even sort of rivalry within the European Union and so on. So if I were the Director General, I would try to have reliable funding. I'll be less donor dependent, try to insulate myself from the shock of a US withdrawal, and not seen an alternative in pleading money from China. That's not, I think, a very desirable alternative. What is interesting is that the US is very isolated in this sort of very short-term approach to WHO and scapegoating WHO. And the moment the US stopped funding and declared its withdrawal, other countries have stepped in. Apparently in the G20, and Tedros said that, I haven't seen other confirmation, Saudi Arabia pledged $500 million, which is more or less what the WHO would lose from the US. The UK is increasing its contribution. Germany has doubled or tripled its contribution. So there is a lot of support, actually, that diversifies funding, and with funding also this distribution of power, if you want, and maybe avoids this sort of showdown between the US and China, which is not very constructive anyway, I think.
I wonder if you could say a little more about the private foundations. By some measures, the Gates Foundation is the second largest funder of WHO. What's their role? Is this project related, or how do you feel about it all?
Well, this one is elephant in the room, proverbial elephant, big. Because Gates has a tremendous power. It's something unprecedented in financial terms, not in historical terms. Because if you look at the development of global health as we know it, it was driven a lot by the Ford Foundation, by the Rockefeller Foundation. Most of the senior public health people around the world were fellows, were deeply connected with Rockefeller Foundation. I think it's not an understatement to say that global health is in good part a US product. But the financial firepower of Gates is unprecedented. So, and that obviously brings ambivalence because after all, I mean, who is the Gates Foundation? Is a largely unaccountable entity, ultimately accountable to a married couple. So it goes against, if you want, accepted principles of good governance, accountability, and if you want, democracy at the international level. At the same time, it has become indispensable. There are WHO programs, for example, poliomyelitis eradication, that would have more or less stopped had not it been for Gates, because there was an intense donor fatigue. And Gates really sort of not only kept it afloat, but shamed other donors in coming back and co-funding the program. So it has also like a synergistic effect. The Gates has its own approach, which is very much based on research, is very much biomedical. This is not a left-wing outfit. It's not a big believer on social justice to achieve health. It's very much research, relatively quick fixes, biomedical approach, project-based, let's find the vaccine and so on. So some people say it's there is a Canadian historian, they call it, anyway, like capitalistic philanthropy. And so it skews, in a way, some of the priorities. For example, years ago, the director of the malaria program left WHO slamming the door because he grossly disagreed with the approach that Gates was more or less imposing by financing a good part of the program, which was very much based, let's find the vaccine, so the more technological intervention, like the more sort of bottom-up social intervention, like bed nets and education and so on. So there is a lot of ambivalence about the effects of Gates, about what lies behind Gates, because if you have $50 billion, obviously you invest them and you don't want to do things that necessarily decrease the value of your investment. So are the motives that we don't see clearly. But at the same time, the factor is becoming indispensable. WHO in 2016, the Health Assembly adopted the first comprehensive policy in the UN system on relation with non-state actors. And what drove that policy was largely Gates and growing ambivalence on the relation with the pharmaceutical industry. But so Gates looms very large, not only in WHO, in some of the big partnerships like the Global Fund, the Gavi Alliance on vaccination, Gates, if it is not the largest, one of the largest funders. So in a way, its weight goes way beyond WHO. And has become, as you said, now if the US really withdraws, may become the first donor.
And it seems like there's a way in which this whole crisis is revealing things that we perhaps hadn't noticed creeping up. And one of them might be the role of these private foundations in global governance. Is it too much to say that you can kind of see now the retreat of the state from global governance and the space is being filled by Gates or some of the other foundations?
Yeah, I would not sort of overblow the point. Obviously, there has been a retreat of the state, including in public health. How much, besides the US, which is a case apart, but you have a lot of privatization of public health in many countries. There has also been a complexification of public health and healthcare, and a tendency of many countries to outsource to the private sector, even rulemaking. That they cannot fully grasp. So let the expert do the trick, and the experts most of the time come from the private sector. So there has been indeed a retreat, but COVID, I think, has brought the state back front row center. Everybody has been looking to states to protect us. Sometimes with draconian authoritarian measures, but also providing healthcare. So I think COVID, in a certain way, has forced governments to take center stage again. For better or worse. So it's an interesting counterbalance to this prevailing narrative of the retreat of the states. Certainly public health has become very multi-stakeholder. And that doesn't please everybody, because multi-stakeholder is always a coded word for private sector creeping in and taking a place at the table. And that to a certain extent is correct. But it's also an area where there is a huge mobilization from civil society, from the left wing of the spectrum, that forces states to step back. For example, using the right to health, using equity, using social justice as strong drivers to counter these more sort of technocratic narrative. So I think it's a bit of a middle picture. But it wouldn't be so extreme to say that the state had disappeared and everything is in the hand of Gates. Gates is a big actor, but among others. And we'll see after COVID how it goes in a way, whether the COVID will sort of size down a bit the importance of Gates, or whether it will come back and you know, push ahead, so to speak.
Right. I wonder if you'd be willing to turn a little autobiographical here, because the years that you spent in the legal counsel's office covered a lot of the dramatic changes that you're talking about. Could you say a little about what that office does and what it's like to be in that role? What kinds of questions are you asked to deal with?
Well, the legal offices of international organizations are less romantic and heroic places than it can seem. Because after all, they're like the General Counsel's office of big institutions. So I participated in the revision of the international health regulations, in the negotiation of the Tobacco Convention. I spent countless hours in the various committees during the Ebola crisis, H1N1 crisis, but at the same time, you do a lot of transactional administrative stuff. So the legal office first of all, it doesn't do health law. There are not many substantive issues of health law that come under jurisdiction of the legal office. Fundamentally, is international health regulation, tobacco to a certain extent, environmental law, and so on. For the rest, is very much governance, institutional integrity, supporting meetings, health assembly, executive board, transactional issues, administrative issues, and so on. At the same time, you're right, I was very lucky because when I moved from the UN, I was in the office of the UN Legal Counsel before joining WHO. And I was dealing with Security Council issues, the Gulf crisis, oil for food. So when I moved to Geneva, I thought, oh my goodness, that's the ultimate backwater. I will get bored to tears. And then politics exploded, and you started dealing with WTO and patent law and biodiversity law. So that was a fun part of the work. As legal counsel, you do a bit of everything. Specialized agencies don't have offices of the size of the United Nations. You have 150 lawyers, if not more, that get highly specialized. In specialized agencies, they are a relatively small office where you need to be prepared to do everything more or less, often under intense pressure, time pressure, political pressure, and so on. But certainly there were, I think, sort of defining periods in terms of the identity of WHO, and the legal office was part of that process.
And you were at the International Atomic Energy Agency as well through an interesting period in its...
Well, end of the Cold War, 88, 89. I left just before the Gulf crisis. That would have been interesting when the agency was trying to find nuclear weapons in Iraq, but I left before that.
Right. So you got out of there before that crisis. You got out of the WHO before COVID.
Yeah, maybe I have insider information that I cannot reveal. How to get out before it's too late.
Exactly. Right. Right. If we're ever at a party together, I'll be sure to leave when you do and not stay 5 minutes longer.
Okay.
So where do you think the WHO goes after this? You talked about the forensic examination of what it did. What do you think is next 12 months look like?
I think the jury is out in the sense that, again, this extreme hostility from the US is not widespread. There is actually a lot of support. There is criticism, mistakes that WHO made, the sort of certain positions that WHO shouldn't have taken. There is some criticism about the Director General, but by and large, I think COVID doesn't show the marginality of WHO, shows how essential WHO is. And this I would take as a point of departure. The next 12 months, we'll see what happens with the US elections, because it will have consequences on the US position. There will be these 2 big reviews going on. I'm sure there will be a plethora of other academic and other reviews, maybe in the UN or in countries and so on. And this all probably will converge on the Health Assembly in 2021. And that's when I think that you will see how mature leadership is in what to do. Because there are many things that can be done to strengthen WHO. The point is, do states want a stronger WHO? And what does it mean to have a stronger WHO? With much more flexible money, so less dependence from donors, with more power to second guess and to challenge states, for example, China in January, if it was the case, with more operational powers. There are so many possible outcomes that you can foresee. I think there is seriousness about COVID and post-COVID. A few things must happen. You need, I think, definitely a stronger WHO, normatively, politically, financially, and operationally. But also you need to look at governance beyond WHO. Because if you look at what happened since COVID, public health has been like the causal agent of a catastrophe that goes beyond health. It is human rights, it is inequality, it is trade, it is investment, it's transportation, financing, agriculture, food. And most of these areas fall under different legal regime, different institutions, different constituencies. To me, what COVID has shown is the lack of an architecture Probably we expect it too much, but an architecture that can help the world sustain a long-term response to a catastrophe like COVID. Again, WHO and the health regulation were not equipped, I think, were not conceived as a driver of a global coordinated response for 1, 2, 3 years. They were like a short-term alert. You need something, to me, to be tragic if we didn't learn from this lesson the need for a serious, if you want, coordination space, institutional space. And not only at the level of secretariat, that we have already. We have incidents management procedures. We have interagency coordination system across the UN. But you need states to take center stage back again. You need a political space. I can't think beyond these generalities, but I see in the literature, in the recent, the current American journal Agora on COVID, this point has been made, I think Jose Alvarez made it, that you need to have this coordination consultation space to try to deter these unilateral, hyper-nationalistic, and very unhelpful reactions that we have seen. Because they create the dilemma, health or economics, health or freedom, and we shouldn't get to that. There should be a more mature conversation, but that requires a more holistic, more complex process that now is missing. So health and WHO should be part of it, but that goes way beyond WHO.
Do you think the US will actually leave next summer when the date comes?
Well, if Trump is so unpredictable that it's difficult to predict what he will do next week, provided he wins the election. I would say if Biden wins the election, no. Biden will withdraw the withdrawal, I'm sure. If Trump wins the election, I wouldn't take for granted that he will go to the bitter end and actually withdraw. I've seen statements by the US recently. For example, there was a special session of the executive board. The US is a member, and they did not speak as a country that is already checked out or that is there just to blast China and increase political tension. It was very sort of moderate statements of a country which is engaged. So I think that the bureaucracy, the real stakeholders don't want to leave. And they're trying to keep their options open and send in messages that the options are still open, and they may convince Trump to remain if he wins the election. But again, I think it's a 50-50. I hope it's a 65-35, not 50-50.
Yeah, thanks. Great. Well, we want to wrap this up at the top of the hour here, but there's
I came 10 minutes late, so if you want to stay 10 extra minutes, it's fine to me. It really depends on you. Yeah.
Do you have 10 more minutes of thoughts?
Yeah, of course. And I see questions. So.
Yeah, so people should feel free to ask a couple more questions if they wish. So you talked about the politicization. You opened up that channel. It's interesting to hear you describe it as coming before COVID, since to the American media, I think the WHO became controversial only this summer when the White House took aim at it. But you've seen the rise of a kind of politicization for 20 years now.
Yes, I think, again, that's what I teach my students. Health is political, but in global terms, I think it became political in the 70s with, developing countries trying to rewrite the rules of the game, also when it came to health. And in the 90s, I think really HIV/AIDS has been a driver, and has broken cross certain lines, broken down certain doors, and keep expanding. For example, the mobilization that you see around climate change and so on, the sort of shaming effect and very combative, highly opinionated NGOs that attack, that shame, that's something that really, the blueprint was written with HIV/AIDS. So it brought politics in public health and public health into the mainstream politics in many ways. So the politicization was there, and it's not necessarily negative because it has to reflect, the broader dimension of the world. And so the WHO will remain a political organization. And I think it will be, the important thing is to understand the limits of what kind of politics can be managed by WHO, because there's still this self-perception as a technical organization. I remember Dr. Chan kept saying, if you want politics, go to the UN in New York. We do public health here. But of course, I mean, that's if you want sort of flipping things around, because it's a different politics. But so if you look at the agenda of the General Assembly, to me, it's very indicative that the health has not figured anywhere until 2001, 2000 actually, when HIV/AIDS was discussed in the Security Council. Since then, 20 years ago, health is on the agenda of the General Assembly or the Security Council more occasionally every year. HIV/AIDS is part and parcel of the UN agenda. Non-communicable diseases, antimicrobial resistant, universal health coverage. So health has moved in part from Geneva to New York. When health issues become more complex, more political, with more agendas converging in that particular topic, there has been a tendency to move the discussion from Geneva to New York. You can imagine the ambivalence in WHO. These are not public health people. There will be too many compromises. The health message will be watered down, will be diluted. But at the same time, probably you need that higher political involvement than maybe you can achieve in the UN and not in WHO. So the politics will remain, but it will go beyond WHO. And so I think it will to me, it will be very important that the UN becomes a more mature, more strategic health leader at the cost of stepping on the toes of WHO. Because the paradox now is that health is more and more on the agenda of the General Assembly, but the UN Secretariat has hardly any health expertise. So all the preparatory work is done by WHO, and a lot of follow-up work is done by WHO. So it's like a validation of the politics that come from New York, and then it sort of trickles down to WHO, to other specialized agencies and so on. But to me, if the UN doesn't develop its own health expertise, then it's a skewed kind of politics. They've seen the technical part in Geneva and the high politics in New York. There's maybe a division of labor, but I don't think that it can be sustainable unless the UN tries to develop its own expertise, its own vision of at least of the big health problems that it puts on the agenda.
It's interesting how you notice a sort of aversion to politics, or a fear of admitting that the work the organization is doing involves politics. One sees this too in the refugee agencies that are so busy describing their work as apolitical, and yet it involves, just like the WHO does, the life and welfare and opportunities and trade-offs among people in a very tangible way that it can't help but be political. So it sounds like maybe you have an idea that there's perhaps a useful convergence here of New York and Geneva agencies, where there's an acknowledgement that we can't escape the politics in the actions of these organizations.
I mean, in part, as you write in your book, it's a consequence of the functionalist dogma, creates international organizations that are there as faithful tools to solve collective action problem, and where the secretariat is apolitical, neutral, technical, does what it's been told. And so that in a way has become part of the narrative of who works in WHO, and perpetuate this image of discomfort with politics. We are a technical organization. It's the same refrain you hear elsewhere, including, as you said, the High Commissioner for Refugees. Also, who is the staff of WHO? 80%, if not more, are public health people, health economists, sometimes medical doctors, sometimes public health professionals. So these are not people that studied politics or practice politics, if not in healthcare and in public health. And so they perpetuate this model. And so to me, what I learned when I was there was a bit of a strange disconnect between the politics that was being played, maybe opportunistically in WHO, and the lack of a solid set of skills in the secretariat that would help them trying to understand what goes on, trying to predict, try to manage a bit. So we were really the receiving end. So maybe, as you said, this division of labor is not so bad. And it can allow WHO to focus on what it does best, which is a normative work, statistic, information, analytical work, and so on, and leaving the political policy setting, at least in more complex areas, to the UN. That's what's happening for non-communicable diseases, for example. The General Assembly has adopted a big declaration in 2011, and there is a series of follow-up General Assembly meetings. But the technical work then went back to WHO, developing indicators and benchmarks and so on. And that maybe is a good, can be a good solution for the future.
And the COVID crisis is such an overwhelming, comprehensive crisis that it's revealing things about the nature of social and political organization and fault lines that, that perhaps were harder to see before. And as you say, involves so many different angles beyond public health, or perhaps it highlights the way that public health is connected to so much else in society. Yeah. And in fact, this conversation here today is the beginning of the COVID and global governance project that we're running, but it's going to be followed up quickly in the next week or so by a series of online essays, a symposium where we are inviting experts from diverse fields to talk about what COVID is revealing in their area. And this involves people from law and engineering and sociology and politics and a bunch of different fields. And we'll have a chance to have a conversation with those people to think through how COVID is really redesigning or forcing us to rethink the ways that societies have been organized. Anybody who wishes to follow that project, or indeed the work of this initiative more generally, is welcome to join our mailing list. In the chat, perhaps we can put up instructions on how people can follow that. And we'll have more of these sorts of conversations in the coming months. But I want to say thank you so much to Gian Luca Burci for his time, for his insight. This is really terrific. Thanks so much for being here.
Pleasure, and hope to see you in Geneva again, in person, not on a screen.
Nice. That'll be terrific. And I also want to thank the Weinberg Center for International and Area Studies for helping make all of this work, especially to Danny Postel and Cindy Pingree for doing all the logistics, and also to Dinara Irazova for helping run the COVID project and getting all that running. And we also have a couple of co-sponsors at Northwestern. I want to thank the Program in Global Health Studies and the Institute for Global Health, the latter at the Feinberg School of Medicine, bringing together so many different perspectives, and we have so much to learn based on all of this crisis business. So thank you, everybody. It was a pleasure not having you here, and I look forward to talking more. Thanks.
Thank you. All the best.
Bye-bye.
Best wishes. Bye-bye.